All right, welcome to our first case review of the year, and this is a pretty interesting case. We don't get to see this very often, and it's rhabdomyolysis. We're going to go over some clinical considerations, some clinical findings to help us be able to detect this in the future. And we're also going to go over the treatments that the crew did for a good patient outcome. So I hope you guys enjoy this. All right. So what we get dispatched to, we mutilated Westview for a sick call, 73-year-old male. Collier conditions means it was a hoarder house, and it was really hard to navigate through. So the engine company from Westview went in, made patient contact. They had to extricate him, which took a little bit of time and delayed that contact for our medic unit. The guy was lethargic, weak. He hadn't eaten, moved, nothing for 4 days. So he had gotten to the point where he just kind of had given up and was laying there. No history, no medications, no drug allergies. As a matter of fact, that was determined later on once the treatment was initiated, because initially he came out and he wasn't making any sense. He wasn't really talking to the point where he could have been a little bit altered. So yeah, and we just don't know how long this guy had been to the doctors. We had a difficult time obtaining some of that information. But so what are we thinking, right? What's going on right now? What's our differential diagnosis? So start thinking of some of the things that can cause you to be lethargic, weak, especially if you were just laying there for a couple days and you have no history. So here's some of the things. I'll give you a couple: sepsis, hypoglycemia, CVA, MI, overdose, AMS due to many things, and then rhabdo, right, which we're going to be going over. So what is rhabdo? I kept this short, sweet, to the point at our level. So the destruction of skeletal muscle cells and leakage of intracellular contents into the circulation. So intracellular contents, this, what's inside of the cell, potassium, magnesium, phosphate, that's what's the highest concentration in our cells. When that starts to leak out, because it's not supposed to be in our interstitial space, it starts to wreak havoc in our body. So that's, in essence, what we're looking for and what's causing it. Exertion, trauma, infection, temperature extremes, whether it's hypo or hyperthermia, drugs, toxins, electrolyte, endocrine abnormalities, and congenital abnormalities. And so what does it lead to? Electrolyte disturbances, hypovolemia, metabolic acidosis, coagulopathies, and myoglobinuric renal failure, which we'll go over here in a minute with Doc in the background. And then Doc brought up also a good point, which is prolonged stasis. That just means a person who does not move for a prolonged period of time. So bedridden patients, maybe a patient who fell down and they weren't able to get up, no life alert. They're there for 1, 2, 3, 4 days. So that's what prolonged stasis. They're not able to move. And then another interesting point is 2/3 of our total body water of humans is held inside of the cells. So once that starts to leak out, we can also, hey, maybe there's that cause of hypovolemia, could be due to that. And myoglobinuria is the myoglobin in the urine. Protein in the heart and skeletal muscles are released into the bloodstream when muscle is damaged. So high amounts of hyoglobin will be in the kidneys as well. That's what causes that kidney failure, kidney damage, amongst the other electrolytes that are leaking out in high concentrations. So here we're going to see dark urine as well because of that.
All your muscle cells have myoglobin in them too, so that spills and that clogs up all your tubules in your kidneys, so your kidneys stop filtering. What happens when your kidneys stop filtering?
Toxicity.
From?
Protein and
Potassium. What is the most common thing we see in people with renal failure? Hyperkalemia is what we worry about, right? So not only do you have spillage of potassium, but now you're clogging up the kidneys and they're not filtering, so your potassium is also potentially going up. All right. Sorry, so all your muscle cells.
All right. So a little pathophys here. Breakdown of muscle tissues, destruction of the myocyte, and distribution of its components into the circulatory system. we briefly went over that on the last slide, right? So one of the biggest things that we're going to see here is that sodium-potassium pump is damaged, all right? And that's so think of ATP as the power source. When you don't have the amount of production in ATP, it decreases because of the damage that's happening to that pump. We start seeing a lot of these abnormalities and a lot of the toxicity in our circulatory system happening, all right? So what happens? Large quantities of potassium and all these other electrolytes listed here start to leak, and we start seeing failure of our kidneys and our massive EKG changes. So our heart also starts to say, hey, I'm not liking this. Something's going on. It tries to create and maintain homeostasis, but it's not able to. Right, so some clinical findings, right? This is kind of the meat and potatoes of this whole thing here. This guy presented with some of them: muscle weakness, muscle tenderness, generalized I'm not feeling well, malaise, nausea, arrhythmias due to electrolyte abnormalities. So the two we're mainly going to be worried about is hyperkalemia and hypocalcemia. We're going to possibly see some shock. We're definitely going to see some acidosis in the later states. And Doc was not too heavy on this, because there's no, what he would say is don't rely heavily on the classic triad. But some of the research that I did described in 3 things, and it's muscle aches, weakness, and dark colored urine. This is just another tool. This classic triad is another tool that if they have one of these, then you can be like, hey, if they have one of these and other associated symptoms, then we should be in a high alert, higher index of suspicion that they might be having rhabdo. So no different than, think about a Cincinnati stroke assessment. They have just arm drift, or they just have unilateral weakness, or their speech is impaired. Just one of the many that can dictate a stroke. It's not conclusive, but you're going to be like, oh man, there might be something going on here. So that's why I brought up the classic triad. If one of those is there and you have some other associated symptoms, raise your suspicion that rhabdo might be happening. Okay. So now some vital signs, right? This is what this patient presented like. He was a pretty normal tensive on the blood pressure. His pulse was pretty high initially, but then it became really high once we started to, do some treatment. Respiratory rate, for the most part, was a little bit tachypnic. Here was kind of normal, but then it became tachypnic. His end tidal was low, kind of showing you some metabolic acidosis here. He's trying to compensate by breathing fast and letting it all out. Put him on some O2. His sugar was a little high, but we don't know what this guy had, right? No temperature. So really right now, the only thing that stands out is he's tachycardic and his end tidal is way low. So there's 2 things we can fix there. All right. So we go straight into some EKG changes, because this is the biggest thing. This is kind of this is one of the things that if we don't treat and we don't recognize can cause death to our patients here. So hyperkalemia is the most dangerous electrolyte disturbance in our patients with rhabdo, and it's because of its propensity to precipitate lethal cardiac arrhythmias. So what starts to happen, right? You see an early onset of hyperacute T waves. That's a classic finding. Once you see those, you should be able to say, hey, this guy has a leakage somewhere. He has hyperkalemia. We need to treat this. We need to be aggressive, right? So the other thing, shortened QT intervals and ST segment depression. We're going to listen to Doc here for a second.
T waves. One is they could be developing an MI. The other is hyperkalemia. So that is a fairly early finding of hyperkalemia. Now, imagine that EKG being a string. Just take out one PQRS complex, and imagine you have a string like this, and you start pulling that string. The first thing that disappears is your P wave. And then that QRS starts widening out, until eventually you get to that. It gets really wide, And if you look at it, go back one, it is almost becoming a sine wave, where I've seen this, where literally the EKG just rolls like a hill. That's all it's doing. And they're barely alive at that point.
All right, so Doc went over a couple EKG things there. Started saying it becomes wider and more peaked. He's saying the analogy of pulling two strings where we're going to lose our P wave, and that's what he's talking about here, right? So these are some of the late changes he was talking about: decrease or disappearing P wave, widening of the QRS. Till eventually we get to the sine wave, and the sine wave is look at the aberrancy here. Look how wide your QRS. This is what it's calling the sine wave, right? And this is suggesting severe hyperkalemia to the point where more than likely he's going to go into a ventricular rhythm only VTAC, pulses VTAC, and he's going to code on you. But the absence of an atrial activity is likely just due to the pre-existing underlying atrial fibrillation, which we're going to find out later that this patient had underlying atrial fibrillation. So if we see this, or even the late changes of the widening QRS and the super high peak T waves, we should be suspicious that the patient might have underlying atrial fibrillation. So this is our patient now. This looks at really, really similar to that widened QRS, late changes, hyperkalemia, and they had a classic sign here. When we were QAing this report, and our medics called the doctor for a consult, this is one of the first things that when they sent him this 12-lead over, is like, this patient has to be hyperkalemic. So that's what we have our medical director there for. We call him, we consult, we share the information, the presentation, the vital signs, we bounce information back and forth, and we do all this for a positive patient outcome, right? So let's involve the medical director a little more. That way he can help us out. He's one of the most valuable resources that we have. All right, so we're going to get into treatments now. If I could tell you one thing that we need to do for rhabdo, that's restoring intravascular volume. We have to have an IV, if not bilateral, especially for severe cases. Think of this as our old school trauma patient, bilateral IVs, fluids going, all right? Except that for this person here, they're not losing blood, they're not losing volume. We need to resuscitate them in the fact of restoring all that IV fluid to the point where they need a pee. The only time we need to be cautious is with heart failure patients, so congestive heart failure, right? We need to monitor for fluid overload, make sure we listen to those lung sounds, and pay attention to our patient. So if they have pedal edema, history of heart failure, let's limit to about 1 liter of fluids. But these patients need IV fluid. We need to stop the progression of muscle destruction. So whatever it may be leading to it, toxin infection, trauma, hypothermia, hypothermia, whatever. Stop that progression and then start treating it with IV fluids. All right, so here's a little chart that I found. And the biggest thing I want you to take away from this is what we see in the field. Everything we can treat with IV fluids. So hypovolemia, IV fluids. Kidney injury, IV fluids. Hyperkalemia, IV fluids. All right, so everything that we would see in the field, we can treat with IV fluids. All right, so we're gonna listen to Doc on a couple things here, okay?
With rhabdo, not everybody necessarily is hypovolemic, right? Right. So the hypovolemia shock comes from a patient who's not taking anything in, and they happen to have rhabdo, right? Okay. That's generally how it is. Now, the reason why we think it's important not to have someone hypovolemic with rhabdo, because the fix, which you're going to go into, is hydration, 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 right, to get their kidneys kicking in and flush out all that CK, myoglobin, and everything else. Now, just to point out, the way you said earlier in the slide, creatinine kinase is released, right? Yep. So that's my measure in the ER to see if you're in rhabdo. If your creatinine kinase is well over 500, you're probably at some level of rhabdo. Now, if you're
All right, and the next thing we're going to talk about is the hypocalcemia, and we'll hear a doc on this.
like, I'm treating rhabdo, I'm not treating hypocalcemia. So just because, unless they have a profoundly low calcium that would affect their EKG and doesn't look like a hyperkalemia, it looks like a hypocalcemia EKG, then I would give calcium gluconate very slowly. That's what I would do. But otherwise, I wouldn't treat it. Now, the hypercalcemia is interesting because what does hypercalcemia present as? All right, so hypercalcemia, you can have altered mental status. So, and the reason why I'm saying this is because a ton of people out there are taking vitamin D like it's their job right now, right? Because they believe that it's the cure-all for COVID, including zinc. So I take vitamin D, but I take 10,000 units every 3 days. I know people out there that are taking 10,000 units once or twice a day, which is nuts. So hypercalcemia presents with altered mental status. You have stones, moans, groans, and psychogenic undertones. That is the classic term we use for hypercalcemia. So stones, they get kidney stones. Moans, they have body aches. They sit there and they're in so much pain, they don't know why. That's why we say the moans and groans. And then psychogenic undertones, they kind of go nutty. They get altered. So we see this often in cancer patients. Hyperphosphatemia, something you see with cancer patients when they have hyperuricemia, hyperphosphatemia, they get cell lysis, that kind of thing. So there, again, we diurese the heck out of them.
All right, now we're going to move on to some of our treatments that we did. Obviously, one unsuccessful IV attempt. We did a 12 lead. We got to see, hey, he's in a fast, what appears it might be ventricular rhythm. Not really sure what's going on. I know I need an IV and some fluids, and I'm definitely going to call a doctor. This medic crew did a great job doing this. They knew they had a critical patient, and this was kind of one of those that, hey, I really don't know what's going on, so let me send Dr. 12 lead and see what's happening. And after consulting with the doc, he said, hey, let's throw calcium chloride at this patient. Why? And the reason he gave was due to the high index of suspicion of hyperkalemia on the EKG. So when he sent him that EKG, he said, hey, I've seen this before. We're going to throw some calcium at him. Now, after a couple minutes when there was no change in the EKG, that's when Doc said, hey, okay, well, we're going to throw amiodarone in case it was an underlying VTAC. Right, because it's a wide ventricular rhythm at this point is what we're seeing even on the 4 lead is showing it. So amiodarone is an all-inclusive antiarrhythmic. It'll work in the atria, it'll work in the ventricles, so it's a safe bet. It's not gonna be detrimental to this patient. And to my understanding, they also continued the amiodarone drip in the ER once they delivered the patient. He took multiple other 12 leads. And there was really no change by the time they got to the hospital. It pretty much maintained this way. So this was a very, very interesting patient. It was hard to treat him in the field. I know that the only thing that the 12 lead picked up, the little guy on our LifePak 15, he was able to pick up that, hey, you know what? After some treatment, there was maybe some atrial fibrillation. So remember how I said earlier, that there could be some underlying atrial fibrillation. Well, this guy had it. This guy had some underlying atrial fibrillation, but there really was not much of a change. If I show you the later on 12 leads, you would say, hey, that really just seems like it's a wide QRS still with peak T waves. So very similar to this. All right, so minimal changes happened after that. But it was able to pick up that it had some AFib with RVR. All right, and then here are some of the changes that we will be seeing in the future. Obviously, our ISTAT, we will go through some training with this. We will be comfortable with this before it rolls out. We will have the Chem H strips, which will measure sodium, potassium, 2 huge things here. We'll understand what levels of potassium are high enough to be treatable. Obviously, if we start seeing EKG changes already, end-tidal CO2 changes, mental status changes, that we're going to be like, hey, this guy, we really don't need a potassium to treat him. We're seeing him right in front of us. But this is another tool to say, hey, it's high enough, we're going to treat it, right? And then, obviously, not really dealing with this here, but the hemocreatinine and hemoglobin, when we get blood products later on. The creatine levels, normally 0.8 to 1.2 is normal, but and that's normally for normal renal function. If we have anything above that, we can say, hey, he's having some renal deficiencies, and we can treat it as well. Again, for us, what it means, we're going to be given a lot of fluids. All right, so what was this patient diagnosed with? Acute kidney injury and secondary to rhabdo. All right, so he had enough of the intracellular contents, electrolytes that were in there, flow out to his circulatory system, and it eventually ended up damaging some of his kidneys. We saw the EKG changes, so obviously it was damaging the heart, and our medics were able to recognize this, use the medical director's help. They were quick on an IV, gave him some calcium, some amiodarone, continued some fluids, and delivered him to the hospital, where eventually, after a week or so, he was discharged. So he got a positive outcome, right? The other thing that they diagnosed him was underlying AFib with RBR, bilateral aspiration pneumonia. We weren't able to diagnose this. The only thing we could have done here was, hey, maybe listen to lung sounds. We might have heard something on the bases, but he was non-febrile, so that's kind of difficult to diagnose. Luckily, he was COVID-19 negative. And normally when patients have pneumonia, they're testing positive for this, but that was a good case for him. SNF is a skilled nursing facility. He rehabbed, and he's doing great now. So this was a very, very good case. These medics did a phenomenal job again. Thank you guys. You know who you are, and let's continue getting better. We're going to try to do more of these case reviews in the future. Guys, one more thing that I forgot to add during the slide. This is from Doc and talking about hyperkalemia. So let's listen up.
Does pacing or cardioversion work in hyperkalemia?
Probably not.
Right. It doesn't work. I've tried pacing someone with hyperkalemia,
I had a
and it doesn't do a
shot.
darn thing. Yeah.
What's the, I mean, is it just...
You need a treat. You need a treat. You can't get capture. You got to remember, the entire depolarization of the heart is completely off. It just doesn't work. So you got to treat the underlying problem. So I gave an order for calcium. What does calcium do?
Hopefully it's going to help with the reuptake in the cells.
So it stabilizes the cardiac membrane. Basically, it blocks all that potassium from affecting those cardiomyocytes. That's what it does. So basically, it blocks it. If you want to imagine, it puts a little shield around the heart and makes it normal. Now, the sad thing with this case is he didn't get a follow-up 12 lead before he got to the hospital, because you may have seen that QRS narrow out some.
So he did get a follow-up 12 lead. We didn't put it in these slides there, but if you wanted, I can show you some follow-up 12 leads.
If you gotten it from the calcium that we gave. What else could we have done to help with the hyperkalemia? And I'm kicking myself for not making him do it because I forgot. What else can you give? We don't have insulin, so we can't do that. What do you have that works on hyperkalemia and shuts potassium inside the cell? No, well, if he's profoundly acidotic, you can give bicarb. It can't help. I'm not going to say you're wrong. We tend not to do that because you're not going to be able to tell. Come on. We use it. Well, we used to use it all the time before COVID. We'll put it that way.
Albuterol.
Right.
That's it.
Did you say that? I didn't hear it.
That's why I said heroin and it's albuterol.
Yeah, that's albuterol.
How does the albuterol work with that?
I can't remember what it does with the beta-2 receptor, but it pushes the potassium intracellular. That's the main gist of it.
Okay.
That's really all you need to know. But remember, it's not give one neb. It's continuous. You're doing 20 milligrams. You're not doing your 5 milligrams.
Yeah, okay.
Yeah. So it's a higher dose, but I should have had him, but we're also in COVID times, so
Yeah, we gotta get
we didn't really need to do that. So I'm kind of glad I forgot